Okay. So, good morning to Shara, Boone, and everyone. So, we'll do like a journal club today. So, we have like a topic association between delay to patient admission from the emergency department and all cause 30 days mortality. So, me and Ankit will do this. So basically, this is like a cross-sectional study. So as a like American student, so I'll go brief on like critical appraisal. But during my like American primary, I have like study like cross-sectional study because we have like 8 or 9 questions from this statistics. So basically, the cross-sectional study is also known as transverse study or cross-sectional analysis, or sometimes a prevalence study. So is it a like observational study that analyze data from the population or a representative subset at a specific point in the time? So this is basically my American primary note. So if you go like observational study, there is a like case control study, cohort study, and cross-sectional study. So basically our today journal club is on the cross-sectional study paper. So it is basically longitudinal individual are investigated at a different time points and determine prevalence, basically relatively simple and quick, and confounding and recall bias will be there and not for a rare disease. So this is basically like for those who are preparing for like American primary. So so this is the like proper paper. So if you go to the page number 1, so the summary of paper is like the topic is association between delay to patient admission from the emergency department and all cause of 30 days mortality, is by Simon et al. So background wise, there is like delay to timely admission from emergency department are known to harm the patient, and the objectives of this paper is to assess and quantify increased risks of death resulting from the delay to inpatient admission from the ED, and using the hospital episode statistics and Office of National Statistics data in England. So basically in this paper they have used like hospital episode statistics for like a patient presented in the emergency, and the Office of National Statistics data in England for like death certificate. So the final comparison is the admission from the emergency department and the 30 days mortality or death. So method is like I said is a like cross-sectional retrospective observational study. So in the observational study, they are like a cross-sectional case control cohort study, but it is like a retrospective observational study. So it is carried out in the NHS Hospital of England. It is a like type 1 major ED. So in this like type 1 major ED means the emergency department which is open like 24 hours within like supervision of consultant. So they have collected data from the NHS hospital in the England, like type 1 emergency department. So the data is collected from April 2016 to March 2018, approximately around 2 to 3 years. So the primary outcome was the death. So death from all causes within like 30 days of admission. And this observed like mortality was compared with expected mortality as a calculated using logistic regressional module. So it uses like a logistic regressional module to adjust for sex, age, deprivation, comorbidities, hour of day, month previous ED admission, emergency admission, and crowding in the emergency department at the time of attendance. So all these are like confounding factor. So we'll go through that one as well. So basically they found as a result between like April 2016 to March 2018. So number is very much. So how to like 26738,514 people attended in the ED, with the 7472480 patient admitted, relating to 5249891 individual patient who constitute the study data set. So it is a large number of like patient from the all the NHS trust from type 1 ED. A total of 433,962 deaths occurred within like 30 days. The overall like 30 days mortality rate was 8.71%, with 95% confidence interval 8.69 to 8.74. The average is 8.71. Statistically significant linear increase in the mortality was found from 5 hours after the time of arrival at the ED up to 12 hours. When the accurate data collection sees like a p-value of it is less than 0.001, the greatest change in the like 30 days standardized mortality ratio was 8% increase occurring in the patient cohort that waited in the ED for more than 6 to 8 hours from the time of arrival. So basically it shows that if the patient waited too long in the ED, it will increase the mortality. But in case of like Nepal, already, so there is no any waiting time in the ED, but in the UK they have a lot of waiting time in the emergency department. And finally they have like concluded delay to hospital inpatient admission for the patient in excess of 5 hours from the time of arrival at the ED are associated with an increase in all cause of 30 days mortality, like between 5 to 12 hour waiting, like it will response effect. For every like 82 admitted patient whose time to the patient bed transfer is delayed between 6 to 8 hours from the time arrival at the ED, there is a one extra death. So like 82 admitted, there will be one extra death if they are waited for like 6 to 8 hours in the ED. So this is like the abstract of this paper. And before going to the proper like paper reading, so basically what is already known on this subject is there is all small studies already conducted in the Canada, Australia, and they have like indicated there is an increased mortality rate among the patient who experience delay in admission to the inpatient bed from the emergency department. And another is like NHS benchmarking 4 hour. Basically, as any doctor, sometime like senior or the consultant registered, they will come and ask us what is the like plan for this patient, because the benchmarking is 4 hours. So within 4 hours, we should have a plan. Like a patient came to the ED, and the time will counted. So within like 4 hours, so we have a like plan whether this patient will go home or discharge home, or it will go admitted, or it will admitted, or sometimes it will be referred to like other specialty. So the there is like 4 hour like benchmarking. So counterfactual modeling has shown reduced patient mortality as a result of like NHS 4 hour operational standard. So they have like put NHS benchmarking network found a coefficient of determination R square value of 0.07 between time greater than like 4 hours in the ED and the hospital summary hospital level mortality indicator. So these are the things that already known before like this subject. And finally the study will add like this study of overall 5 million NHS patients shows an increase in all cause of 30 days mortality that is independently associated with the delay to hospital admission from the ED rather than the crowding alone. Another is the standardized mortality rate start to rise from like 5 hours after the patient time of arrival. So it will be increased after like 5 hours of like ED waiting time. And another is like increased effect of long stay in the ED before inpatient admission can be measured and represented as a number needed to harm metric. that is after like 6 to 8 hours is already. So if 82 patient is there admitted, if there is a like a 6 to 8 hour waiting, then there will be one extra death. So this is the overall paper. So now we'll go to the proper like critical appraisal things. So first, so we'll use the this is the JBI critical appraisal checklist for analytical cross-sectional study. So it has like the 8 questions. So if you see on my right side, so we have like 8 questions. So first 1 to 4 I will do, and from 5 to 6 Ankit will do. So we have like 4 questions. So we'll answer as, no, unclear, and not applicable. So we'll go to first question. So whether the criteria for inclusion in the sample clearly defined. So the question says like provide like clear inclusion and the exclusion criteria. So if you go to the page number 2 and the box 1, so you'll find like there is a like further information about data handling, inclusion criteria, and the incomplete records. So they have clearly explained regarding like what are the included, what are excluded. So they have used like hospital episode statistics data. So this is for like patient in the emergency department, and another is Office of National Statistics mortality data. So it will explain about like death certificate. And so these two data are linked by NHS Digital before release and provided in the table coupled by a pseudonymized unique patient identifier. So basically they use like two data. So one is from hospital episode statistics, another is Office National Statistics mortality data, and they have linked off with NHS Digital, and they give a like a patient identifier. So patient admission data were included when the data of admission, patient identifier, primary diagnosis, and the admission code were all present. So they have excluded those who don't have like a patient admission date and time, patient identifier, and the primary diagnosis and the admission code. So they have put some admission code if they are present, and they have included. Otherwise they will exclude all the data. So where the patient had a multiple emergency attendance in a single day, the final attendance of the day was counted. So like if some patient came like multiple time in a single day, then they have put like a final attendance of the single day. And also if a patient came in the multiple time, then they have put like a first admission as a like proof, like within like 2 hours. So I'll go through another paper, so it has explained about that. So if there is a multiple attendance, then the final attendance, if they presented the different date, then the first admission will be included in this paper. So another is ED data were included when the both arrival date and the arrival time were recorded. So the date and the time if recorded, they have included. So the data set for use was created by linking admission to ED, presentation by means of unique patient identifier. So basically they use like patient identifier, and the ED presentation were linked to the admission when they occurred one same day as a admission or on the day before. So basically the time frame is like within like 12 hours. So if more than 12 hours, then they have excluded. So it says like the same day admission or the on the day before. So all the admission without like corresponding ED presentation were removed. Thus during this process, all the admission by the ED were linked to the valid ED presentation in the data, and all the admission had valid diagnosis and the patient identifier. That's all. Like if they have included, if there is like data of admission, like date of admission, time of admission, a patient identifier, a primary diagnosis, and the admission code. And so finally what they found is like a patient with the data that that could be process compromise and the essential part of the selection criteria for the study. It was, of course, impossible not to exclude patient with the incomplete or missing admission data or record that could not be matched. The incompleteness and the inaccuracy of many record and the prior cleaning undertaken by NHS Digital makes an exact estimate of their number very difficult. So basically, they have done many things, but finally they have concluded that it is very difficult to exclude all the things. But so at the later stage, 4,714, 0.09% of patient out of total 5254605 individual patient were excluded because the lack of key variable, that age and the or gender. So they have clearly mentioned regarding inclusion and the exclusion criteria. So if you go to the page 2 method study design, so it also said only a patient first admission in the study period was included because it was considered that there were too many confounder with a multiple attendance. So here, so one thing is, if patient arrive in the ED in the same day multiple time, then the last presentation will be included. But here in if the patient came within 1 month, 2 months, then the first admission is taken in this one. So they have included this one. But the patient who waited in the ED for longer than 12 hours were also excluded from the mortality analysis, as a temporal data were found to be unreliable, and after this point the number were relatively small. So if a patient waited for more than 12 hours, they have excluded from this data. So this is the first question. So the inclusion and exclusion criteria is clearly mentioned. So do you have any comment on this first question, where the criteria for inclusion in the sample clearly defined? So my answer is yes.
I would agree, that was extremely comprehensive.
So then we'll go to question number 2, where the study subject and the setting described in detail. So the answer should include there should be a clear description of the participants selected or recruited. There should be a demographics and location and the time period. So if we go to the paper number 2 in the data sources, so they have clearly mentioned, they have included from the NHS England Hospital episode statistics record of the ED attendance, and linked to the hospital episode statistics admitted patient care record, and the Office of National Statistics population mortality data. So what they have done is, so first they have included from the A&E first ED attendance, and another is admission record, and another is the National Statistics mortality data. So for death certificate, so they have included 3 data. So first, a patient will arrive in the ED, and if they are admitted or discharged. So if they are admitted, they have included in this one. And another is if the patient die within 30 days, and they have included. So all the 3 data they have already clearly mentioned here. And hospital episode statistics data include both range of clinical, demographic, administrative and geographical variable, and 30 days mortality data were identified linking hospital episode statistics data to the Office of National Statistics data. So they have included all the geographical and demographic variable. So the later the data set contain detail relating the person death, including the date and the cause of death taken from the death certificate. So they have get death certificate from the Office of National Statistics population mortality data. So they have included everything, but finally they have concluded that the published record on hospital episode statistics data quality and the percentage of data linkage, so that these data, although incomplete, but cover most of the admission and 30 days mortality. So they have included everything, but because this is the large data, so although it is incomplete, but cover most of the admission and 30 days mortality. So if you go to the data section in page number 3, table 1, so it included a demographic characteristic, like the male is around 48% and female is 52%. Previous emergency admission, age wise, average is 50.27 with a median of 55. They have included from 25 to 75 years of patient, and hour of attendance, month of attendance, and the year of attendance from 2016 to 2018. So for question number 2, where the study subject and the setting described in detail, so my answer will be yes. So any comment?
No, you're doing brilliant.
Okay. So we'll go to question number 2. Now here is some problem. So what the exposure measured in a valid and reliable way? So to answer this question, so we should have describe the method of measurement of exposure. Like a validity wise, there should be a gold standard is available to compare, and for reliability there should be epidemiological study to check repeatability of measurement of the exposure. So to answer this question, it is a bit difficult. So we discuss, I discussed with Ankit as well, whether we should put as no or not clear. So finally, what I get is there is some study ongoing, the study is in Canada, Australia, China, also in the England as well. But basically this paper, it is not clearly mentioned which gold standard they have used, but they have somehow mentioned here there is some the study has already done and there is some problem, but the author, they did not clearly mention which is gold standard they have used for validity and for reliability. So for question number 3, so my answer will be no or unclear. Exactly, I don't know, so I need help from Sarah. So.
I think your conclusion is actually sound. This particular critical appraisal tool is not a perfect fit with the type of exposure this study actually looks at. So the exposure is a catch-all term for anything that might have happened to the patient. And in this case, it's the wait time in ED, obviously. And so the outcome is the 30-day all-cause mortality. So there's no gold standard way of measuring the wait time. And they've taken their statistics from the most reliable places they could. There is no better data set. So they've gone with the Office of National Statistics for the mortality. They've gone with the hospital episode statistics for the rest of the data. They've gone with the best that they could. So no, it's not badged as gold standard, but you've looked at the right sections in the paper and the question is not especially helpful. So looking at it in a very pure sense, no, it's either unclear or no, because there was no gold standard. But considering what they had available, I think they've made the best choices for the data that they've chosen and the sources of those data. So yeah, it's kind of, I'll stick with your conclusions, but I think they've done okay.
Yeah. So thank you, Sarah. So my last question is, were the objective standard criteria used for measurement of a condition? So to answer this question, we have to there should be maybe some selection bias or to decrease the risk of bias, what they have done. So if you go to page number 2, statistical analysis, so it has mentioned to minimize the selection bias for time in the ED, that is older or sicker patient waiting longer because they take more time to treat. A logistic regressional model was used to predict 30 days mortality. So the author, they done like a lot of jobs. So for like selection bias, so to minimize this one, so for the like time in the ED, they have used like a logistic regressional module. So this is the like new term. So if you go through like a logistic regressional module, so they have like excluded, they have done like some modification to include like a time in the ED for like older and like sicker patient, because for like older and sicker patient, it will automatically take a longer like a period of time to like treat them, to have for like older patient, we have to take like history from like sometime from like care home, sometime from their like next of kin. So it will like take time to decide whether the patient will be like admitted or it will be discharged like within like a 4 hour of like a benchmark. So they have like modified using like a logistic regressional model. So like for like question number 4, where the objective standard criteria and used for measurement of condition. So my answer is yes. So any comment?
No, I think that's fair enough. I mean, it's again, it's a question that isn't perfectly suited to the style of the study that they've done. So, you know, what is the condition? It's every condition that anyone presented with at ED. But I agree with the bits that you've pointed out there. So it's not a great question because they just admitted everybody. But it's you're looking in the right places.
Okay, so this finishes my first like session. So second session will be by Ankit from 5 to 8. So Ankit, you can start from my side.
Yeah, thank you, Sundar. Thank you. Yeah, Sundar explained everything about the paper quite nicely. So yeah, so we'll start with my part of the session. So yeah, so the last questions I'll be doing are the last 4 questions from the JBI critical appraisal. And let's start with the first question is, where the confounding factors identified? So confounding factors are the estimates where the intervention exposure effect is biased by presence of some difference between the comparison group. And yes, the authors, they did a good job in identifying the confounding factors. Like they identified the multiple attendances, A's, 6, and time in ED. So the answer to this question is yes. So, and if we look at this table, they have mentioned all the confounding bias in the table and calculate the mean as well. Okay, anything, Sarah? I think the answer is yes to this question.
I agree with you. Yes, they've gone to extraordinary lengths to identify all of the things that can affect mortality and then try and account for them. I think it's a genius bit of work, to be honest. Yeah.
All right, thank you. So let's move on to our next question, that is where strategies to deal with the confounding factors stated. And yes, so the answer to this question is yes again. So they have used this logistic regression model, which Sundar talked about. So they use this model to describe the confounding factors. And you can see in the statistical analysis section. So to minimize the selection bias, they have used this logistic regression model, and which helped in predicting the 30 days mortality. So yeah, so the answer to this question is again yes. So we can see in the table number 2, they have given the logistic regression model that is used to predict the 30-day mortality. So we can see, so they have nicely given the previous admissions, ED attendances, and they have used some Elixir comorbidity index for the comorbidities as well. So, and you can see that the highest odd ratio goes towards the 4-hour breach in ED, which they mentioned as the highest predictor for mortality. Yeah, so the answer to this question is yes. Anything from the audience? Yeah, Sarah, yes, Sarah.
Do you have a clear sense of how they certainly they built the statistical model, but I was interested in where they hunted for the data that would help support that, for example. So do you think that using crowding, so they have a proxy for crowding because they know it's a factor, and so they were using like 4-hour breach data. Does that feel suitable? I'm wondering, so the question is what were their strategies to deal with all of the individual confounding factors? Did you get a sense that they'd chosen appropriate proxies, or that they'd sought their data in a sensible way?
I think they tried their best to sort the data, but by seeing that the previous attendances, so the 4-hour breach doesn't tell the whole story because it's different for every patient. So yeah, it's not totally clear, but I think they did a good work using this model.
I think so. I mean, there are gaps, and they did identify that there was some factors they couldn't get the data on. So they didn't have, there's nothing in here about patient acuity, staffing levels, bed occupancy, the things that create delay. And they didn't have that data, but I guess they can't do absolutely everything.
Yeah, I think in the end of the prepare in the discussion, they have mentioned that still they were not able to get all the confounding factors. So yeah, that would have made this study more great. So yeah, they have written in the discussion section of this paper as well.
Yeah, okay.
Yeah, so the next question is were the outcomes measured in a valid and reliable way? So to answer this question, the answer is obviously yes to this question again. So yeah, they have used the appropriate statistics to measure. They use this SMR, standardized mortality. They calculated this standardized mortality rate from the logistic regression model that they divided into the patient factors and ED factors, and they found that with the plotting, they plotted the standardized, they calculated it first from the total number of death observed, sum of the observed death by the total number of estimate that they found the standard mortality rate, and they plotted it against the time. And they found out there was a linear rise after 240 minutes to 720 minutes. That's after 4 hours to 12 hours. So, and yeah, so there was a linear increase. So yeah, you can see in the graph as well. So there is a, after 240 minutes, so there is a linear increase. So they have described in the here in the figure 1 as well. So the SMR for all cause death was plotted against the duration in ED for time of arrival. So yeah, so yeah, so this is the reason I think they have done a good statistical analysis. And they also found out in the logistic regression model that the highest odd ratio for mortality is 4-hour breach with odd ratio of 1.35 and a p-value of 0.001. And they also calculated that there is one extra death for every 82 patients who are delayed for more than 6 to 8 hours in ED. And the answer to this question goes yes. You can see the odd ratio.
Summary. That was excellent.
Yeah. Okay, so and the last question is, was appropriate statistical analysis used? And again, yeah, I think, yeah, so with this cross-sectional kind of study, so it's a regressive analysis which they have done. So with the regressive analysis, they should answer the two questions, that which variables were included and how they related with the outcome. So they have mentioned almost all the variables that they could And they also have related their outcome as well. In table number 2, we can see that they have used the logistic regression model, and they have found out all the odds ratio, which contributed to the mortality, 30 days mortality. So although they might not have received all the variables as Sarah mentioned earlier, which was not mentioned, but they did their best. And I think the answer to this question again is yes.
I agree as well. There's a statistic that they give that you haven't mentioned, and it's complicated, and it's also written in tiny type. At the bottom of table 2, they give the ROC curve statistic.
Yeah, ROC curve.
Did you make anything of that?
Yeah, I couldn't make much of that, but
no, it's now can I do this really straightforwardly? It's assessment of kind of precision for the statistics. So it's plotted. Hang on, let me refresh my memory. It's plotted looking at sensitivity and specificity, and they give. I've got a little diagram. Hang on. Can I nick your screen share and show you the diagram?
Yes.
And then bear with me. Oh, not that. Oh God, should have got rid of all my things up, shouldn't I first? Hang on, we'll get there. Not even that one. Oh, I'm such a professional. There. Okay, so the ROC curve plots sensitivity and specificity. This would be an ROC statistic of 0.5 and not very helpful. What you're looking for is the here, the area under here. As the number for the statistic gets higher, then the curve bends up so that this is very good. So a specificity, if the curve is up here, and so this would be stats like 0.8 and upwards, which is what they found. Yeah. Identified their statistics accurately. There is not a sense that there's a large false positive rate. It is in fact a true positive rate for their statistics. I'm not explaining this particularly well, but you can visualize the number of 0.82, which is what they found, is a curve that is much, much closer to the true positive rate than it is what 0.5 would be, which is basically the diagonal line. So it's meant to be a visual representation of how accurate the statistics are in terms of identifying true positives as opposed to false positives. That was a bad explanation. I'm going to stop sharing.
Yeah, thank you, Sarah.
You're kind.
Yeah, I think, yeah, and the answer would be yes, isn't it, Sarah, to that question as well? Yeah, yeah. So I think that was the last question. And I think overall the paper, they did a really good job. And yeah, they've given us very good information. Like they used, I think Sundar already explained about everything. So among the total people they included, about 5,249,000. So they calculated a crude 30-day mortality rate, which was 8.71. They calculated the mean spent time in ED was just under 5 hours. And the breach of 4 hours was about 38%, which is quite high. So and they did plot the death in a linear fashion from after 5 hours arrival in ED up to 12 hours. And yeah, so, and they also advised at last in the for the healthcare policy should make timely admission to ED to avoid hospital associated patient harm. So yeah, and in the discussion they have also mentioned that this further studies could be improved by getting more confounding factors. And yeah, overall a very good paper to me. Yeah.
So
we can thank Boone for identifying this one.
So the for final message to like all the like ED doctor, if the patient waiting for more than 6 to 8 hours, then every 82 patient one, like there will be extra death. So be careful while seeing patient, get like a proper idea, get like senior help involved early phase. So we can like push within like 5 hours, we'll have like a good plan. A patient will be discharged home or admitted. That's the like a final message. So be careful. That's it. Thank you.
Thank you both. That was excellent. And it's such a punchy paper, isn't it? There's so much data and they handled it so well. And you presented it really clearly. That was great.
Thank you.
One question for the floor. This paper suggests that, obviously suggests, together with previous papers, that delay causes extra death. The question, I suppose, we have found the association. So this paper shows association. We always have to be careful in terms of when we look at statistics to be aware of the difference between association and causation. So we have found the association. I think there's no question about the association presented here. But what about the causation? How strong do you think this association that is shown here points towards causation? Because the next thing you need to think about, if you think there is causation, is you need to think about because we're all clinicians here, is to look at the data and say, okay, we found the association, but what do you think is causing it? Why is there this association? Is that a valid question, Sarah? Because I think there's always confusion between association and causation among clinicians when they look at data.
I think, Boone, you've hit the nail on the head, quite frankly. I mean, the people who come to any and by type 1 patient ambulance, they are unwell, okay? And, the causation is not essentially that is the wait in A&E or delay in admission. I think they might be having some sort of underlying pathology which is developing and which gets serious, and they've not made clear that one, that whether these people have been operated on and there was a complication of operation, or these people have been thrombolized, there might be a bleed due to thrombolysis or something. They've not given that reason. It's just an association. And I think, yeah, you're right. So, there's nothing for us here which we could work on and improve on, apart from that we create an extra 100 bed or something like that, So,
yeah. I mean, I was discussing with Sarah about paper selection for today's journal club, and this was my suggestion, this particular paper. And I wanted this paper because of two things. One is it's very topical. In other words, we know about all this delay, we know about this flow issue. But actually, I also wanted to show that we need to be careful about causation versus association, because the other thing that you need to think about when you look at a paper is, okay, there's a delay, and patients with delayed planning or whatever, that has increased risk of mortality. But actually, are there a different set of patients that end up with the delayed plan compared to the ones that you discharge within an hour? Are they very different patients? Are you comparing apples and oranges? I think that to me is something to think about. I'm not saying that that's the answer. I'm just saying I wanted to bring this up as a point when you look at papers, and just be careful. Well-written papers, well-written with all the correct statistics put together, you still need to look at as clinician, you need to look at the meaning behind the numbers. The numbers may be correct, but you need to look at the meaning behind the numbers, if that makes sense.
No, it does. I think in this paper, they were not looking at any causation. They were just looking at an association. And, Yeah, so I think the paper technically they have tried their best to make it quite technical, quite convincing.
Technically the paper was written immaculately, but I'm just saying as interpretation and how we use the message from the paper is the other question. As
You're absolutely
clinicians,
right,
we
yeah.
need to be careful about, and that is the whole point of a session like this today on a
You're
journal club.
absolutely right.
It's good paper, well written, good statistics, everything is spot on. You know, they use national data, but actually, have we thought about why it's happening? That is the next layer, I think, clinicians in journal clubs need to be looking at. So when you so we are all in a process of learning, as this journal club is, as we are all aware. But I just wanted to bring the extra element now, because they're now starting what? We're now about 6 months into this whole journal club thing. So
Yeah.
let's start looking at not just the numbers, not just look at whether the validity to the whole paper, but just look at the meaning behind some of these papers that are being discussed.
But that's the whole point of critical appraisal is.
Yes.
Absolutely. That's the fundamental.
It's not just
essence of
looking at the validity of the numbers
You're
and the
absolutely-
statistics, it's the validity of the meaning behind what they're trying to say or show. And how that impacts on our practice, on what you do as a clinician. That's the most important endpoint of a journal club session.
Absolutely agree. Yeah. Because it's the aim is to develop the mind, critical mind, developing critical mind, whether this particular drugs which we administer, is it a placebo effect or is really work or is psychological or what, you know?
I mean, there's no doubt it's really important to be able to look at the paper and analyze it using the various tools. But that's the starting point. That in reality is the starting point to see whether the paper can be accepted or not in the first place. Because if it doesn't even pass the various tools that we've used for the last 6 months, then we don't even get to point number 2, which is actually, is there a point in actually accepting this paper?
No, the other thing
So
is
there's 2 parts to it.
yeah, the other thing is, whether NHS will adopt this paper in their policies. I doubt very much, because the 30-day all-cause mortality, 1 in 82 person. So NHS won't budge. So that's another thing. So will the NHS spend so much money that the delay in any? No, we have better. We have got 12-hour delay now.
I mean, if I were the investigator, I would use this paper as evidence to get more funding, to then look at the causation.
Yeah, right. Yeah.
You know, if I were the investigator, this is the evidence to show that actually more work needs to be done to look at why it's happening.
So you mean political tool? We use it as a political tool.
You use it to try to get funding for the next step.
Yeah, you're right. Yeah.
That to me is what's obvious about this paper. Is there is evidence that something's happening. The next question is, why is it happening? What's going on? But then you need support, you need funding to look into that, because it's actually an important question.
Bon, I've got a question to you regarding what you mentioned about the causation and association. That's absolutely correct. And I feel like you will be at pressure by managers looking at these kind of review articles and mention that, okay, look, we need to push off and we need to actually work on to seeing the patients as soon as possible and getting that priority kind of diagnosis to start with. However, that always is not the case. And some patients are gone through a rafting, they didn't find a place. That's why they're loitering around. Doctors, they didn't know exactly where the patient is. These time delays, we don't know exactly. So as clearly you mentioned about the association and causation part of it, I was just wondering, what answer would you give to them in terms of do we accept it right away or not? I know on the funding part, we can't really talk to them right away because that's not at that point in time. So at that point in time, what would you suggest? Is it more like we cannot conclude based on this evidence versus any input from your side in terms of what else can be done apart from the extra funding and getting another study done?
So the question is, what's causing the delay? that hasn't been answered in this paper.
Right.
We know that the delay causes extra mortality,
Mhm.
but what hasn't been answered is what's causing the delay. And really,
So do
is
you
it
think
is
that
it not
review-
enough? Is it not enough staffing? Is it not enough staffing? Is it not enough hospital beds for them to be discharged to? Is it not enough? Is it a delay in transport home? What are the factors? And remember, so if a manager just used this as a blunt tool, personally, my answer to them would be, this just shows association, but it doesn't really, still doesn't show what's causing it. It's a very blunt paper. The statistics
do you
is
think
very
that
blunt.
interview to some of the subjects, like let's say, for example, nurse in charge, another one is one of the clinicians, another one is HCAs, another one is paramedics. All these can be involved to make sure that, okay, all has been listened to, and this is what we've come across, like more of interview sessions in the methods. So that might actually give us an idea. I know it's not like a qualitative method
Yeah.
to present, but interview would be, I think, the ideal way to see whether there could be a causation. Do you think?
Like I said earlier, this paper gives evidence that there's something going on, and gives you but the evidence to say we need to look more into this. That's all this paper does. There is
So,
but we need to look at why.
but Boone, I think the paper, when we critically appraise paper, so there are types of paper as well. So, what is this type of paper? What this type of paper, like quantitative, qualitative papers, like association, causation. So I think from very beginning, from the introduction of the paper, so the speaker should make clear that this paper is heading toward that side, so then that confusion will go away. Some sort of method.
Yeah, I mean, to be honest, the main message that I wanted out of this paper is to let everybody be aware the association versus causation question.
Yeah, you're right.
Because clinicians make this error all the time. It's very common.
It's just keeping cool head, really, when you study paper, or especially when you try to apply paper to your practice. So keep your head cool, think on various aspects, and and then adopt that paper in your practice, really, because your practice will impact on the people's life. So so we have to be careful when we change our practice. And
yeah, I mean, if, for example, if this paper not only showed association, but it actually then dived deeper and showed what's causing the association, then this paper will be published in a much higher impact factor journal.
Yeah, you're right. Yeah,
because this paper just sort of stop at step number 1, and really the higher level paper journals, they want the step number 2, which is what's causing it. But it's a good paper. I'm not saying it's not, but I'm just saying.
I think the paper on causation, probably they need a lot of effort,
Yep.
a lot of funding,
It's
a lot
much
of
harder to do.
research.
This is why they publish at the point of association.
Yeah, you're right. Yeah. So, and I think cause the paper giving causation might well be far and few between.
Okay. Shall we move on to Sarah? Shall we move on to second paper? I think we're now at 10 o'clock, which is we've taken a lot longer than we thought for the first paper.
No, but we've actually reached the stage where you're having a decent discussion about the evidence and what you might do with the evidence. I feel like it's we're really getting there.
That's Journal Club for you.
I mean, you can imagine when we started and now, how much a difference. Excellent.
Yeah. Okay. Sarah, I'll let you take over. I'll shut up now.
Oh no, no, you're good. Right, let's have our next presentation then, please.
So now we have like a second journal club by Dr. Tanvir and Dr. series. So it is on the randomized control trial. So are you guys ready? Or
Hello.
hi, Sirish.
Hello there. So, shall we start? Shall I share? I am the first one going on. So,
Yeah, you can share.
am I visible?
Yeah.
Okay. Good morning, good afternoon, everyone all around the world. So we are still in Nepal. Today, me, Dr. Shirish Bora, and Dr. Tanvir Ahmed, my colleague. Today, we're gonna present the case. So the topic for today, which says in CASP RCT checklist for the short-term topical tetracaine is highly efficacious for the treatment of pain caused by corneal aberration, which is a double-blind randomized clinical trial by Siftman et al. So I hope some of us had the time to go around the article first so that it would be easier for us as well. So let's we have divided into, this has been divided into 4 sections, A, B, C, and D. I will be going for the A and B, while Dr. Tanvir will be going for C and D. So I will be moving on with the first question. So did the study address a clearly focused research question?
Is it your slide moving, Sirish? Because we are seeing just first slide.
Really? I guess it's moving in my side. Shall I do it again?
Yeah.
Click in the slideshow.
Yeah, I guess I have clicked on the side. So is it working now?
No,
Can you
just
click on the
one.
next slide now?
Is it working?
No.
No. If you
know how to
close
click
your
slideshow?
presentation and bring it back up again, it might work better.
So if you like close every slide and close every slide and now share the slide and open the new presentation, it will work like that.
I'm sorry. I'm really sorry.
It's fine. It happens to me as well. It's very frustrating.
Yeah, it's frustrating sometimes.
You got a nice picture under your thing.
But that's my wife.
Then I'm coming to Nepal.
I'm so sorry.
Oh God.
I guess this is okay. So is it working now?
Hey,
Yeah,
that's it.
it's working now.
Yeah.
I'm really sorry for the trouble. So let's start again. Okay, going to question number 1. So did the study address a clearly focused research question? So I have gone for a yes, because as you can see in the article in page number 339 and 340, the goal has been specifically defined. The goal was, the aim of this randomized double-blinded trial was to compare the effectiveness of topical tetracaine versus a placebo. They have also given a comparator here in the ED patient with corneal aberration as measured by the numeric rating scale pain score at the 24 to the 48-hour follow-up examination. The selection of the participants, they have also given the age was specific. They were also taken a written consent. The outcome they want to measure, they were specifically written that the endpoint of the study would be the overall NS pain score that was taken before and as well after the 24 hours and the 48 hours. The secondary endpoints would be the how much hydrocodone were ingested when they had a breakthrough pain group, either in placebo or in the tetracaine group. So I've gone for a yes in this question. Shall I proceed?
Please.
Okay, so the second question is, was the assignment of the participant to the intervention randomized? So for this also, I have gone for a yes, because in page number 339 of the article, there has been specifically written the eligible patient were randomized in 1:1 ratio to receive the tetracaine or the placebo. A computer random generator and randomized were performed with numerical sealed opaque envelopes issued in a sequential order to the physician in row to the patient. All these were given by the ED physis. They contained an antibiotic solution, which they had to apply, whereas they also gave a hydrocodone and acetaminophen, whereas they also used the samples of tetracaine or the placebo as study drops as well. They have also included exclusion criteria also. They have taken all the samples from day or night and the 7 days as well. They have a lot of exclusion criteria, such as using the contact lenses, previous corneal surgeries, and which were presented in 36 hours of injury, after 36 hours of injury. If there were any penetrating eye injury or retained foreign body, they have excluded everyone. So I think, yes, this was randomized because they have done 1:1 ratio.
Now, there's one of those prompts in the question on the checklist is the most interesting bit. And that's, was the allocation sequence concealed from investigators and participants? What do you think the answer to that bit is?
The sequence was concealed to investigate. I thought it in that way because they have kept the name as study drops. They have kept it in an envelope. Yes, they've done a little bit there that they have used only 1 bottle for tetracaine and they have used 4 for the other one. I'm sorry, the placebo. So maybe they would have known. The other thing they may know is by when you use a tetracaine, you have a burning sensation in the eye. Well, whereas when you use a placebo, you don't have it. Maybe so I was doing it the first time. I thought I should go for a Cantel, but I went for a yes because they were trying to do it their very best.
Yeah, yes and no. So yes, I agree they randomized them, but I can't agree that the allocation was concealed from the investigator because I mean, they've made the point that they used opaque envelopes. Well, that's marvelous. That stops you holding something up to the light and seeing if there's a number written in it. What it doesn't stop you is feeling the envelope.
Feeling it, yes, exactly.
4 ampules in that one and only 1 in that
one.
So they might not know what's in the ampules, but they certainly know that they're different. So I was disappointed with their the kind of allocation concealment. They definitely randomized them in quite a basic way. But there's another question that's going to pick up more about the blinding from the patient's point of view. So I'm glad you've identified it, but bring it up in question 4 as well.
So moving to another question, were all participants who entered the study accounted for as conclusion? So I would like to take you for a chart for this. So this is in page number 341. So the first, they took around 283 were eligible. Among them, 165 patients were excluded because 115 did not meet the criteria. 44 declined to participate, and 6 of them, they have not given a reason for it. Among 118, they allocated in 2 groups, 1:1, that is 59 to 59, whereas 3 patients were lost due to they could not follow up in the tetracaine group, whereas 4 patients did not follow up in the ED group. At the end, they had 56 analyzed in the tetracaine group and 55 analyzed in the placebo group. This is not 1:1 ratio, but they have tried to minimize as much as they could because they have also written that they have in page number 339, they have 340, they have written that they have telephoned and contacted every one person whom they could, and they could reach as far as they could be possible. And they have excluded these 3 and 4, total 7 people. But I've given a yes for them.
I think at the 24 to 48 hour point, yes, I think dropouts are minimal. I think if you took that right through to the very end of the study,
yes,
it's not so minimal. How many people actually came back at a 1 week point for their chat?
I've written it somewhere. Yes.
Let's see, where's the data on that?
At the end, the 56 came in the tetracaine group, 55 were analyzed in that group.
Yeah, so that's at the point where they were assessing the immediate pain scores. But at the very end of the trial, they wanted to find out how much medication had been consumed during the trial as their secondary outcome. Let's have a look. Oh, I should have highlighted it myself. I actually think their dropout rate was colossal. They've got something like only 20% actually came back for their chat.
Yeah, 20% in tetracaine group and 18% in placebo.
Oh, yes.
Yeah, okay. So in the characteristics of study groups, yes, 6 responded to a text message of the people who complete. So 49 patients. Let me see, where is that? In the characteristics of studies on page 340.
340.
Of the 48 patients who did not complete all follow-ups, 16 responded to a text in the treatment group, and in the placebo group, 45 did not return for their 1 week follow-up. Bless them. They lost everybody, didn't they? That's okay. You're answering the questions accurately based on that chart, and it does give you good data at their primary outcome point. But basically they had to write off their secondary outcome. Sorry, carry on.
So moving towards the 4th question. So were the participants blind to the intervention they were given? Were the investigators blind to the intervention they were giving to the participant? Were the people assessing, analyzed outcome and blinded? So for this, I'd like to start in page number 339. Yeah, the participants I thought were blinded because everyone, I don't think the patient will know that whether it was a tetracaine or just because it was hurting or not. So it was given by the ED5 as well. They had generated a number and everyone was given in opaque envelopes. All they did was a mistake was that there was 1 bottle for tetracaine and the 4 bottles for placebo. So I thought this would not, the participants will not have known, I guess. So I given it a yes for it. Whereas for the investigators, we're going to do it in the second as well. They have said that they would generate a number. And from there, after 24 to 48 hours, when they come and the doctor who is evaluating them on the pain score and looking at the corneal ablation, he is also blinded that he does not know which medication the person has been using. And the processing that they have been done was done from the statistical group, from the Excel. They have entered data without, I'm sorry, patient identified into the custom database constructed in Microsoft Excel. So I thought all the 3 of them were blinded in this trial.
I think that they set out that way. They intended that to be the case, but you said it yourself before. The tetracaine hurts. So it only needed the patient to say on their follow-up appointment, geez, what did you give me to put in my eye? That hurt worse than the original problem. And they know what they received. The blinding is off the minute the patient opens their mouth.
They have also specifically written in the end part as well that they didn't ask the question themselves. But I guess the patient would have surely said it because they surely have hurt their eye.
Yeah, yeah. It's unavoidable in that circumstance, actually. But it's quite naive of them to pretend that the observer did. But I agree with the way that you've assessed it. It's just it's a reality, isn't it? They would.
Yes. So moving to the 5th question, were the groups similar at the start of the randomized control trial? Yes, I've given it a yes as well because they have specified the age group as well. They try to take a written consent as well. They're going to take it in any time, 7 days a week as well. They have set out a fixed exclusion criteria so that they only get simple corneal abrasion as well. They have also added one thing in them is that they wanted all the people they have taken who can read and write English and Spanish. Other ethnicity were outcasted, but still I would like to say it was done in US. So yes, it goes for a yes in this question as well.
Yeah, I mean, I would have had a good look at table 1 for the baseline kind of clinical and demographic characteristics and just have a really good look and see if the groups were similar. Occasionally, and randomizing the groups, not even, they're random, but they're not evenly matched. But one gives you that clue as to how they were at the baseline, and you can spot any weird percentages or numberings. But I didn't see any particular problem.
I also didn't say any problem, but so I took the selection of participants as the main thing so that everything will be justified in the written form.
Okay.
So moving to our question number 6. So apart from the experimental intervention, did each group study receive the same level of care? That is, were they really treated equally? So I've given it a yes because of this reason. As we can see as well, everything the envelope contained was similar beside the placebo or the tetracaine. They were given specific instructions that if you have much more pain, then you can use hydrocodone as well. They have given it to apply the placebo or the tetracaine 1 drop every 30 minutes in the maximum of 24 hours. They have also limited the times, but it was exactly the same they wanted to do with both the things. So yes, at the end, I will say a yes for this question as well. And the recording that was done was done in the similar pattern after they came to the 24 hours mark. The NRS score before and after was checked in the same pattern. So overall, I think, yes, the plan was same. The treatment pattern was same. The material used beside the tetracaine and placebo was same. So they were treated equally. So I have given a yes with this as well.
Yeah.
So this was section A and B from my side. Now I'd like Dr. Tanvi to join and go further till the end. Dr. Tanvi, would you like to share it yourself?
Yeah, I think I will share it from my computer.
Thank you. Thank you.
Good morning, everyone in UK, and good afternoon, everyone in Nepal. I'm Dr. Tanvir Ahmed, and I will be covering the rest of the questions in the CSP checklist. So the section C is really concerned with what are the results. So before we move forward with the questions, I would like to go through what the article says. Researchers have tried to measure these outcomes. The primary endpoint of the study was the overall NRS pain score measured at the patient's initial follow-up in the ED visit. Secondary endpoints were the amount of hydrocodone ingested for breakthrough pain and any adverse events. The primary data analysis was done via Microsoft Excel. The data were entered without patient identifiers into a custom database, and the analysis was done through an add-on package in the Microsoft Excel itself. The calculations indicated that a sample of approximately 60 patients per group would have 95% power. And the main results were as follows. At the 24 to 48 hour follow-up, the overall NRS pain score after use of the study drops was significantly lower in the tetracaine group, that is 1 versus 8, compared with that of patients in the placebo group. The difference was of 7, and 95% confidence interval 6 to 8. P value was less than 0.001, and there was a greater difference between the patient's overall NRS score compared with their baseline pain score in the tetracaine group versus the placebo group. The tetracaine group reported using the study drops more times, that is 9 versus 5 in the placebo group. The number of patients found to have a small residual corneal abrasion on their repeated emergency department slit lamp examination was similar between groups, 10 of 56 in 18% in the tetracaine group and 6 of 56, that is 11% in the placebo group, with 95% confidence interval. Yeah. The overall pain rating at the 24 to 48 hour follow-up can also be seen with from a chart. The tetracaine group had a relatively lower pain score compared to those from the placebo group. And at the end point, the overall NRS score at 24 to 48 hour follow-up, as I have already discussed in the previous slide, tetracaine had 1 and placebo had 8 with a difference of 7, and secondary endpoint, that was number of hydrocodone tablets recorded. In the tetracaine group, it was only 1, while compared to placebo, it was 7 with a difference of 6. And the adverse events recorded in the tetracaine group was 3.6% as compared to placebo, that was 11%. Also, they did not specifically ask the patients whether they knew what group they were assigned to, as this could have biased their outcomes. As Sarah has already pointed out, the burning nature of the tetracaine that could have unintentionally unblinded the patients. So now going ahead with the questions, where the effects of intervention reported comprehensively, then things to consider are, was a power calculation undertaken? They have done it, so my answer is yes. What outcomes were measured and were they clearly specified? We have already seen they have clearly specified the outcomes they were measuring, so my answer for this would also be yes. Were the results reported for each outcome in each study group at each follow-up interval? I think the answer to this question is also yes. Was there any missing or incomplete data? I think the answer to this question would be no, because the dropout, the patients that dropped out and did not come to the follow-ups, their data were not collected for the research. So I don't think there are any missing data for this one. So I'm giving it a no. Was there differential dropout between the study groups that could affect the results? I'm not really sure about this one. So I have written can't tell, because the dropout is, not similar. In one tetracaine group, there were 3 patients were missing in the follow-up for the 24 to 48 hour period, and in the placebo group there were 4. So I'm not sure if that would affect the results. Were the potential sources of bias identified? I think the researchers have done a good job with this, and they have identified the biases. Were the p-values reported? Again, my answer to this question would be yes. I would also like to ask Sarah if my understanding of these questions are correct, and she can correct me anytime if I'm wrong.
Sure. Okay. Now I've got some slightly different answers to you, but I will happily explain why I see things a little bit differently. So yes, the first one, power calculation, it was undertaken, and they decided they needed 60 in each arm of the trial in order to adequately distinguish a difference in pain score. Unfortunately, by the time they'd lost a few people off each side, they didn't actually have 60 people in each arm, so they were underpowered to detect the difference in pain scores, which, that's a shame. They're not far off, but they're not there. So even though they found a very distinct difference in the pain scores, you have to bear in mind was a relatively small trial. The smaller the number of people in the trial, the less sure you are that they've found the difference they're claiming to find, essentially. It's a problem. It depending on the size of the dropout rate, I guess. If you're far away from the amount of people in the trial that you needed, you know, they pressed on with it regardless, but it's a shame. Were the outcomes measured? Were they clearly specified? Yes, that's all fine. Results reported for each outcome in each study group at each follow-up interval. Well, yes and no. So they certainly reported at the 24 to 48 hour mark. That was fine. It's at the week follow-up point, which no, that really didn't happen, did it? They attempted to contact people, they did try, but they don't have data at that point. And this is it follows on the next point. Was there any missing or incomplete data? I mean, they basically don't know what happened to these people. If this was a really serious piece of research and you were trying to make sense of that massive number of dropouts, you would have to assume that all of the dropouts had some dreadful corner. You couldn't assume that they didn't. And that wouldn't half mess with your results. When you don't know, you have to take the kind of more pessimistic view about what's happening to these people that have dropped out of your trial. So they've completely ignored their secondary outcome. They just sort of dismissed it because they had no people. And that's a shame. But it is a bit of a problem. There is a massive amount of missing data. The differential between the study groups, no, I don't think, up to the point of the 24 to 48 hour mark, no, I think the dropouts are quite small. If they're less than 20%, then it's fine. The potential sources of bias, well, I think the biggest two sources of bias are the disruptions to the blinding and the concealment of allocation. So if the patients chatted after if two patients on the trial bumped into each other in the corridor and started talking, they would immediately know that they were on different arms of the trial, and that's not great. If the clinicians knew from feeling their opaque envelopes that they were giving out two different treatments, that's not great. The worst thing really is the fact that the observer at the 24 out of 48 hour point could easily know which were in the placebo group because they would have had no effect from saline drops, and the tetracaine group that would have complained about burning, essentially. And that destroys the trial. If you haven't got the blinding in a randomized controlled trial, you haven't got anything really when you're attempting to blind. And it's not always possible to achieve blinding. Some interventions are exceptionally difficult to provide an adequate blinding. You think of acupuncture, or when you're actively doing something to a patient, you can't blind that easily. But this is a problem because they attempted to blind and it was a write-off. And the people.
There is one thing I don't understand though. The blinding was done pre-enrollment, so I think it shouldn't matter if they, later on discover what part of trial they are in, the patients, and also the doctors didn't ask them. So I think the blinding was done properly. Wasn't it?
But if the doctors suspected, observer bias creeps in. If you know what you think you're going to see, do you see more of it? So if they knew that patients were in the placebo arm, were they expecting to look and see a worse outcome? It's very subtle, but I do think that is a really big problem with this study.
Yeah. Okay.
Sorry.
I'll move on with the other questions then. So was the precision of the estimate of the intervention or treatment effect reported? The question suggests us to consider the confidence interval, and I think the researchers have reported the confidence interval to be of 95%. So I think the answer for this would also be yes.
Okay, right. So have you got a bit of the article that you could bring up to show some of the confidence intervals? Because that would be quite handy. Let's have a look and see what would be useful. Because yes, they've reported confidence intervals, but for example, any chance that you've got table 2 that you could show? Otherwise, I'll bring up a copy and we'll have a look.
I think I'll have to stop this share and share again. Would that be okay?
Sorry, say that again.
I think I'll have to stop sharing the PowerPoint.
Oh, I see what you
and
mean.
share
Yeah.
the
That's a good plan. Yeah, if you're able to do that, we'll have a little chat about that confidence interval.
Okay. Okay. Can you see my PDF?
Yeah, that's perfect. Okay, so this is the only real time that the secondary endpoint is useful, because they did create a confidence interval for the number of adverse events. So what they're looking to do there is to compare whether the number of adverse events were worse in one group or the other. Now, a confidence interval gives you the range of results that they found. It's essentially saying, if we repeated this study 100 times, we're 95% confident that the results will appear in this range. That's what the confidence interval indicates. So the fact that the confidence interval is a 95% confidence interval isn't the interesting bit. It's actually the numbers in the brackets on the right-hand side of that little table 2 under difference. So they're giving a difference in the adverse events of 7.4, and then in brackets, they give the range. So it went from -2.9 to 18.6. The longer the confidence interval is, the more doubt we have that they've actually found something sensible. And there's a really clear indication here that there's a problem with that result. I mean, we know there is, because there wasn't enough people at that point in the trial to know what they'd got or not. But the numbers go from a minus number to a positive number. And interpreting a confidence interval is much easier if you mentally imagine it stretching across something with a line of no effect at, well, in this case, actually, the line of no effect is set at 0. So at where the confidence interval stretches across 0, and when it goes from a minus number to a positive number here, it's crossed the line of no effect. So honestly, you don't know if that's true or not. So you can't take any sensible conclusion from the adverse events that they found. So yes, reported confidence interval. No, it's not actually very useful.
Yeah, thank you.
On
Thank
the
you
answer to
for
that
explaining
question.
that. Now, regarding the complications, the reported complications in the tetracaine group, there were 2 complications. Two patients came with worsening corneal abrasion in ED follow-up examination. Patient immediately referred to study ophthalmologist, and the outcome was additional diagnosis of allergic conjunctivitis was made, and normal healing by 10 days was advised. And in the placebo group, 6 patients came with worsening corneal abrasions in the ED follow-up examinations, and the ophthalmologist made a diagnosis of iritis and prescribed steroid drops, and told them the normal healing days would be 10 days. And similarly, there were worsening corneal abrasions in placebo group, and the additional diagnosis of traumatic uveitis was made, and other complications were also noted in other patients, similarly like uncomplicated corneal abrasion, or a foreign body was also observed in one patient. So coming to the next question, do the benefits of the experimental intervention outweigh the harms and costs? Now, the things to consider in these in this question are where harms or unintended effects reported for each study group. So I think the answer is yes, because they did. And was a cost effectiveness analysis undertaken? No, they did not. So the answer is no. There was one more question. I have removed it. I think because it was not applicable to this RCT.
Okay. So what was your conclusion then? Is this
I think
intervention
yeah,
you'd want to use?
I think yes. Because it definitely outweighs the harms and the cost is not so high. I will explain it in the later slide also. So I'll move forward.
Sure.
So coming to the section D, will the results help locally? So before we move forward, I would like to point out the limitations in this research. First of all, this study was not powered to establish safety for rare or adverse events that could be associated with topical anesthetic use. To demonstrate safety, a much larger sample would have been needed. And the second limitation that I thought is important is although the researchers attempted to blind patients from their allocation group, the burning nature of the tetracaine may have unintentionally unblinded the patients. Additionally, patients may have been unblinded as a result of the placebos having been packaged in 4 ampoules versus the tetracaine in a single bottle, as we have discussed earlier. Now the questions are, can the results be applied to your local population or in your context? Are the study participants similar to the people in your care? I think the answer to this would be yes, because uh, simple corneal abrasions, there are a lot of people coming with simple corneal abrasions that fit the inclusion and exclusion criteria in in our emergency department here in Chitwan Medical College as well. And so I have given this question a yes. And would any differences between your population and the study participants alter the outcomes reported in the study? I don't think there would be any, so I've given it a no. Are the outcomes important to your population? Yes, it definitely is. Are there any outcomes you would have wanted information on that have not been studied or reported? I have given it a yes, because I think even a simple corneal abrasion can be a little uncomfortable, and most of them are work related. So the researchers should have also, I mean, assessed uh, how long it takes for the patient to be comfortable to go back to work, because some of them might be involved with heavy machinery and they can harm themselves or other in the at the workplace. So I think they should have added that question as well. Coming to the other question, are there any limitations of the study that would affect your decision? I don't think there are any limitations, so I've given it a no. Um, shall we move ahead, or would you like to comment?
No, we're really in, I bow to your clinician's experience here. This is the other half of the critical appraisal balance. Is the study valid? I can help pick holes in that. It's how you apply it. This is entirely your thing.
Okay, thank you. I'll move by with the other question. So the other question is, would the experimental intervention provide greater value to the people in your care than any of the existing interventions? So I thought of a benefit, and the most important benefit is that it reduces harmful effects of opioid and help in reducing opioid crisis. It is safe for short-term use if the diagnosis of simple corneal abrasion is proper. A longer, if topical tetracaine is used for a longer period in corneal abrasions, it can cause delayed healing and can also cause a lot of complications as it is written in our textbooks. So I think the diagnosis of simple corneal abrasion is important, and if it is, I mean, properly made, done, it can definitely reduce the harmful effects of other painkillers that the patient would otherwise be prescribed. Now, coming to the appraisal summary, uh, what the researchers did is it is a prospective double-blind randomized trial of tetracaine versus placebo set in the emergency department. 0.5% tetracaine versus saline drops given at 30 minutes intervals as much needed for 24 hours. And the exclusion criteria were if the patient had arrived 36 hours after the initial injury, if the patient was less than 18 years of age or more than 80 years of age, if the patient wears contact lenses, if they had previous corneal surgery or transplant in the affected eye, if they had coexisting ocular infections or grossly contaminated foreign body in the eye, penetrating eye injury, allergic to study medication, or injuries requiring urgent ophthalmologist consultation, that is corneal ulcer, large or complicated corneal abrasions with vision loss, etc. um, Pregnancy, and inability to fluently read and speak English or Spanish or attend follow-up. The outcome of this research was that the primary endpoint of the study was overall NRS pain score measured at the patient's initial follow-up ED visit. Secondary endpoints were the amount of hydrocodone ingested for breakthrough pain and any adverse events. Now coming to the results, at the 24 to 48 hour follow-up, the overall NRS pain score after use of study drops was significantly lower in the tetracaine group compared with that of patients in the placebo group. There was a greater difference between the patient's overall NRS score compared with their baseline pain score in the tetracaine group versus the placebo group. The tetracaine group reported using the study drops more times than the placebo group. Now, my conclusion to this research would be short-term topical tetracaine is an efficacious analgesic for acute corneal abrasions and is associated with less hydrocodone use compared with placebo and was found to be safe in this sample. I would also like to add a few more things. Even small corneal abrasions can cause significant topical ophthalmologic anesthetic was in 1818. A cocaine derivative was employed to effectively block nerve conduction in the superficial cornea and conjunctiva. A number of proposed dangers have limited the use of topical anesthetic agents for the treatment of corneal abrasion associated pain. These dangers include delayed healing, secondary to mitosis inhibition, and decreased corneal sensation. The latter issue is of concern because of the potential for the abrasion to progress to an ulcer without the patient noticing. Additionally, these agents may have direct toxicity to corneal epithelium with prolonged use, leading to increased corneal thickness, opacification, stromal infiltration, and epithelial defects. The fear of these complications has led to the pervasive teaching that topical anesthetics should never be used for outpatient management of corneal abrasions. This is reflected in the condemnation of their use in major emergency medicine textbooks, including Rosen's. Some of the evidence used to support the claim of local anesthetics causing corneal harm comes from case reports, animal models, or local anesthetic injected directly into the anterior chamber of the eye for cataract surgery. But these are old information, and there is a blog post. I think if anyone is interested in it, they can go through it. It's called Rebel EM. So they have highlighted all the previous studies that have been done for topical tetracaine and the newer ones as well. And they have also come to the conclusion that for short-term use of topical tetracaine, it is safe, relatively safe. So I would like to end my presentation with this note. Thank you.
Thank you both. That was a very clear presentation. We had a difference of opinion on some aspects of it, but I very much enjoyed your work there. We've got to 11:15. Any thoughts from the floor, as Boone says? In which case, may I suggest a short break before we have our final presentation at 11? Is that okay with you, Sundar and Boone?
Sounds like a good idea.
Great. Should we come back at 11 then? Or do you want 10 minutes? 5 minutes to stumble in?
Whatever everybody else wants. 11? Let's make it 11.
Yeah, I think 11 is all right.
Let's come back at 11.
I was quite enjoying listening to that turn into Cher doing it.
Thank you.
Thank you.
Hello, everyone. Hi, Sarah.
Hello, Tilak. How are you?
Yeah, I'm fine. How are you?
Good. Long time no see.
Yeah.
So
I'm
what are
in
you up to?
Nepal. So,
You're back in Nepal.
yeah.
I'm really glad you're joining us.
Tilak, how are you?
Hi, Mr. J. How are you? I'm
So
fine.
how is Nepal?
Yeah.
It's
Nepal
a,
is same as it was 2 years back, so nothing has changed
okay,
much. So.
nothing changed there. So weather-wise, is it cold, hot, or what?
Yeah, it's cold weather now. Like it's not that cold, but around like 15, 16.
Oh, yeah, that's a very nice temperature, is it?
I'll take that.
Yeah. So how far away you live from mountain? Because Nepal, they've got a nice field area as well as if level ground.
Yeah, so mountain and they are not like that far, but the problem is the road. So basically like the vehicles will take hours and hours to go over there due to the hills and everything. So I think like the nearest mountain would be like, is it in Pokhara, like 4 hours? Pokhara city. And again, if you want to go to like base camp or something, then you might have to walk for another 3-4 days. So it's like that.
Oh,
if you want to cross the mountain, then it's like 3-4 days walk.
God.
Yeah.
Did you get to the Lake District when you were in the UK? I know you went to Scotland, didn't you?
Yeah, I went to Scotland. Scotland was kind of like similar as yeah, Nepal. Yeah. But like our mountains are like very high mountains, but like
Yeah, ours look really feeble in comparison, don't they?
No, Scotland, really, they're not mountain, are they? They are little hills and beautifully green and stuff like that. So them mountains are very high in Nepal and Everest, K2, God.
I think I'll just share my screen in the meantime.
I think that's a good plan. I think it's really secretly there behind the completely blank images and lots of mute.
Is everybody here? It's almost time, is it?
It's almost time.
Yes, sir.
Oh,
Yes,
yeah.
I think we should start.
Looking good. Okay. All right, like in your own time, then I think you may as well make a good start.
Okay, thank you, Sarah. Good morning, everyone in UK, and good afternoon, everyone who are in Nepal. Today, I am doing a systematic review. Let's start. So basically, so when you hear the term systematic reviews, it is analysis of the like available literature. So my literature was also one of the systematic review. The topic of the like literature was evidence-based for point-of-care ultrasound for diagnosis of skull fracture in children, or systematic review and meta-analysis. The authors were Georgios, Eva, Arthur, and Danny. I believe like everyone have gone through the articles by now. So let's go through the aims of the study. So they have clearly mentioned about the aims of the study. So this is the portion from the article itself. So it mentioned as to evaluate the sensitivity, specificity, positive predictive value, and negative predictive value of focus in identifying the skull fracture in the children. And this is the conclusion part. So they have also like clearly included the conclusion part as focus is a valid option for diagnosing skull fractures in children visiting the ED after blunt head injuries. So again, this is the flow chart of source strategy and selection, basically mentioning how they selected. So initially they had like 781 articles in the systematic review. Then so like few of them were duplicate, so they excluded duplicate, and 545 were remained. And then again they screened 530 and they put their eligibility criteria, and using the eligibility criteria, so they selected a 16 articles. So out of the 16 articles, they went through all those like 16 articles and selected the best 7. And So these are the 7 best articles that they selected. The first one, Weinberg from USA, Riera done in USA, Bari done in Italy, Rabiner done in USA, Choi done in South Korea, Barry done in Italy and USA, and Maseli done in Iran. So these were the 7 basically studies that they took for their systemic analysis. So basically today I'm using a JBI tool. So basically it stands for Joanna Briggs Institute. So it was developed in Australia, Adelaide. So it is one of the widely used tool for systematic review and critical appraisal. So basically it also, JBI also mentioned about the systematic review. It mentions that the systematic review is essentially an analysis of available literature and a judgment of effectiveness or otherwise of a practice involving a series of complex steps. So these are the checklists, JBI checklists. So I'll be doing the first half, 1 till 5, and Dr. Suraj will be doing 6 till 11 of this checklist. So let's start. The first question was, is the review question clearly and explicitly stated? So I think like the objectives were clear. I already mentioned the objectives. So basically they want to see if the focus is effective in children for identifying the head injuries. So the objective was clear. So I'll say yes. Source strategy was also well explained, as I showed you in the previous slide. So out of 547, they selected only 7 articles for the systematic review. So they did it pretty well. And basically JBI especially focused on 4 component: population, intervention, comparator, and outcome. So basically they have mentioned about the population and all their in the comment table, and they have mentioned the outcome well as well. So the answer for this question is yes. Anyone wants to give feedback or anything then? Okay.
No, go for it.
Yeah, we have a table, is it selection criteria, inclusion, exclusion. Yeah, you've shown it. Yeah.
Yeah, so they have generally mentioned about this study population, but it's kind of again, we'll go through others eligibility criteria. Now, they have presented the everything well, and they have written authors have gone through this all the articles and have made clear of this objectives and outcomes. So I think the first question would be as. So
have you got a slide earlier on that actually just set out who they were choosing and that kind of thing? So
yeah, so this one.
No, I was thinking that when you take an excerpts from the that's the kind of thing. Yeah, let's see. I was thinking just to pull out exactly their population. So children with skull fractures due to blunt head injury that were confirmed by CT, that kind of detail. That's okay. So when the question's prompting you for the PICO bit, it's hold it in your head if you've got it sort of laid out that way. So we know who the children are. It's obviously about POCUS, point of care ultrasound, and the outcomes that they're going to consider in the review are sensitive, specificity, and the negative and positive predictive values. So just to hold in our heads, that's the point of the systematic review, and then you can go into the detail about how they addressed it. That's fine. Yeah.
Okay, so let's go to the second. So this is the first question. So let's go to the second question.
That's the one. Sorry, I've jumped the gun. Sorry.
So were the inclusion criteria appropriate for the review of the question? So though they have mentioned about the flow chart strategy, but they haven't mentioned about the particular inclusion criteria and eligibility criteria is so they have mentioned the duplicates were excluded, but they haven't mentioned what kind of study they have screened out and what were their criteria what were their eligibility criteria. So there was no any specific mention about inclusion or exclusion criteria in the whole literature, so they didn't did it well. And again, like they have mentioned about children with blunt head injury who visited the ED were included, but in like 2 of the studies there were children, there were patients of more than 18 years of age, and like they haven't given like any specific age group. Like in few studies there were children from day 1 till 2 years of age, and like few studies like there were like patient of more than 18 years of age. So basically there was no any like specific age group or like an inclusion criteria, so they haven't mentioned it like well how they included these things, so the answer will be no. So as I mentioned, like no inclusion and exclusion criteria.
But they've mentioned the median age 13, is it? Tilak?
I don't know if TLAC's frozen screen there. We may have lost a connection for a bit. Oh no, we lost you for a minute there, TLAC.
Hello, sorry about that. I think like my internet just like it went, so sorry about that.
No, you're good. So no, I think you're right. They're a little bit hazy, aren't they, on who they've included and excluded, although they're quite clear about the data that they're dealing with. It's a bit of a strange setup.
Yeah, so like they haven't like clearly mentioned what was like age group inclusion criteria and why did they screen like the out of 547, how did they screen like 530, and why did they select the 7? So they haven't mentioned it clearly. And as I mentioned earlier, even the age group of the children, few were from day 1 to like 2 years of age, and in few studies like there were like patients of more than 18 years of age as well. So the answer for the second question will be no.
They didn't even explicitly state what kind of study design they were going to hunt for in the search strategy, although they knew what they needed. It's just a bit odd.
Yeah, so they didn't mention that as well. So this is the same thing as I mentioned earlier, like in 2 studies, there were patients of 18 years and older. Again, the third question is, was the search strategy appropriate? So I think like they try to source like all the like Ovid, Medline, Cochrane Library, Google Scholar, Web of Science, and Embase, and they source for the term like skull ultrasound, child and fracture, and they came up with 547 articles. So I think like they did pretty well for the source strategy.
Did you click the link in the article, because it does take you to the supplemental information for this one, and they laid out their actual full search strategy, which was very interesting to me and probably a lot less interesting to everybody else.
Yeah, like few things that I mentioned that I have mentioned like later on as well, because they have mentioned like in the article that they have included everything about when the articles were published and recent articles, what there were articles from 1995 to 2007 and 8. So there was a bit of difference in the like reference section as well. Though I didn't went through all the like references one by one, but yeah, I thought there was a bit of like point on that like timeline of the article as well. So
see, one of the things that I particularly wanted to try using this JBI critical appraisal tool, because it is a little bit different to the CASP one, is because it asks just slightly different questions. And one of them is, was the search strategy appropriate? So the areas that they've mentioned here, search syntax encompasses skull, ultrasound, child, and fracture. They're search concepts. That's not the strategy, but I will cut to the chase and say, I've had a look at the strategy and it looks great. So that, the answer to the question, was the search strategy appropriate? Yay.
So let's go to the fourth question. So were the sources and resources used to source for the studies adequate? So I don't think they were adequate enough. So I think like the source strategy were adequate, but as I mentioned earlier, like they haven't like clearly mentioned about how did they screen, and like there was no any like eligibility criteria. So though they have came up with 547 articles, but they didn't mention clearly about like how did they selected the criteria. So I don't think they went through like enough resources, and as Sarah mentioned earlier as well, like even the references were not like that updated, or like they didn't have like proper, there were very few references. So I don't think they did like proper sourcing and resources. So
I think in their defense, they looked in the right places. So searching online with a good search strategy, and then searching again in Cochrane, in Embase, they looked in the right places.
yeah.
Question 4 particularly is prompting you to consider, did they exclude articles unnecessarily? And I don't think that that's the case, because they didn't put a language limit on, for example. They weren't just limited to their own language. They did check reference lists. What they didn't look for is unpublished material. So they only were looking for things in the easier places to find, I guess.
Yeah, I think this was the case. And the last question, were the criteria for appraising studies appropriate? So I think like there were like lots of bias in the like study as well. So basically like they have divided the studies as low risk of bias and high risk of bias. But if you go and see the table, so out of the 7 studies, so 1, 2, 3, 4, 5 studies were at the risk of the bias. So they were high risk of bias, only 2 were low risk of bias. So overall, their like article was like at high risk of bias. So I think like
they did choose an appropriate criteria. They did choose an appropriate tool to assess that with, though. So they used the Quadras tool, and that's exactly the right thing to look at diagnostic test accuracy studies and assess their, quality, if you like. So that I'm more in favor for that.
Yeah. And again, like as I mentioned earlier, so there was no any specific mention of year of publication. So they have mentioned in the data extraction section is like, so year of publication, study characteristic, baseline population, but like I could not find any year of publications written in the table or chart. So it was also kind of not appropriate. Yeah, I think that's all. So explain my first 5 questions. Do you want to add anything, Sarah?
No, I was just looking actually for the year of publication. I think I've found it, although you do have to dip and dot. In figure 2, where they present the weird looking forest plot, they've actually put the years next to the studies there, and they don't do that when they mention the studies in other tables.
Yeah.
I don't know why, but they did include it at least once.
Yeah, they have included it once.
No, I agree with your conclusions, and you've mentioned everything that needs mentioning, so thank you.
Thank you, Sarah. So,
I think the diagnostic ultrasound, is good. It can, because the skull bone is what we call it is a flat bone, which got 2 layers, one top and one bottom, and the spongy in the middle. What they call diploid, I think there's got. And the ultrasound scan, logically can diagnose fracture, if we do properly, because of the advantage of a sandwich in between the 2 layers of the bone. So you can pick up fracture if we do properly.
yeah, like the other thing that was a bit not right in this article was, so they have mentioned about different kind of like the just a second. So they have mentioned about the experience of the clinician for doing the focus. So like few of the clinicians were not like qualified, and few have done like 1 year, 16 hours of focus training. So even though like training time was not specified, so there was a variation in the training time for the ultrasound as well.
I guess that's the role of a systematic review, is to take all of these different elements that are present in the different bits of research and see if it is possible to come to a conclusion. And that's that is part of the systematic review process. They're dealing with very different types of factors in each of the studies.
I think the other thing is risk of intracranial bleed and a fracture. So I don't know. I mean, we used to. I forgot now. So how many patients might have an intracranial bleed if they got a fracture? So that's, I don't know. That's need to be looking into it. I mean, it's a good set of risk stratification, is it? Because the children, we know practically that CT scan is absolutely very difficult. One is the downstairs still, there's a radiation. We can't have our parents, sometimes we have to have our parents in the CT room, but it's quite a risk of radiation. So I think ultrasound scan is one of the modality which we should be using a bit more often. So in our department, the question is whether we will be doing, or we will get the help of a sonographer, trained sonographer. I mean, to me, even if we have to request ultrasound by a trained sonographer, that's probably worth, rather than going to the CT scan and sedation, everything else, because there's no fracture. So at least you can say that we've done a scan, so risk of having a brain injury or intracranial bleed is quite less. I don't know, that figure need to be looked at. If there's a skull fracture, so what proportion of the patient have a intracranial bleed? I think there's a certain numbers, but I don't exactly remember now.
Well, is that going to come up in your half, Suraj?
Yeah.
Or we can have a look at we can have a good debate after that, shall we?
Yeah, that's fine.
Great.
Yeah, I think I will start that way. Tilak, have you finished your part, or?
Yeah, I have finished, but I will stop sharing.
I'm sorry, guys. I don't know what's wrong with my video. It just I use the phone as well as the laptop. I think it captured the phone one, but not the laptop. If I put the phone one on, it'll be a lot of echo. So is it okay if I just go with the whatever I have in the laptop? Because the presentation is in the laptop.
Yeah, sure.
Sorry about that. I should show like how to fix that, but not right away. I'm sorry about that. Let me see if I can say that now. Right, everybody can see.
Yeah, we're seeing
my presentation. So what I'm going to do is I'm going to close this and then open it again, save it. Is it thing like 24 one? Right. Can you all see my presentation?
Yes.
I'll check if it goes well or not. I'm still not there as a ghost, but hopefully you'll find me somewhere. Right. My name is Suraj, one of the CSER trainee, and my topic today is evidence-based for point-of-care ultrasound for diagnosis and skull fractures in children, a systematic review and meta-analysis. And today we're joining for the critical appraisal for this article itself. It's a meta-analysis article. So as Tilak already mentioned, it is accumulated from a series of studies, and finally the outcome is given after the right kind of analysis. So just a bit of background about head injury NICE guideline and what exactly it suggests in children. For children who has sustained a head injury and have any of the following, to perform a CT head scan within 1 hour of the risk factor being identified. One of them is suspected open or depressed skull fracture. This is what we are focusing at the moment, nothing else. So let's move on to the other one. So the current practice, CT is usually requested with the discussion from my ED consultant and then with the duty radiologist. They have been found out that increased incidence of cancer in children and young people associated with the diagnostic radiation by CT. Medical professionals must weigh the benefit of CT scanning. So that is where we are not exactly doing the non-invasive part of it, because we don't see the radiation clearly, but most of the time it's invasive, especially in the childhood age group. And although this study has actually got like less than 2 years to about 25 years of range of age, and that being said, from 18 years onwards, they have separated it. So basically 2 years to 18 years is the actual study age group that they have mentioned. Skull fractures associated with traumatic brain injuries, subsequently clinical decision algorithms have to be developed that incorporates clinical suspicion of fractures. CT is a reference standard. However, they expose children to radiation. Another thing is point of care ultrasound is rapid, non-invasive, and that can actually use to identify skull fracture, more of ruling out than ruling in most of the time. Right. The checklist I was following is Jbi checklist, as Tilak already mentioned. I could actually put that in the reference section for you to check if you want to go into it. You can actually download it from there, and this is what the questions I've got so far. Was critical appraisal conducted by 2 or more reviewers independently? I would say yes, because I can give you some evidence. As you can see in the selection portion, it says 2 reviewers, GA and EV. That's the initials of the authors. They were the ones who reviewed, basically independently screened the titles and later the abstract, and then later on they screened the remaining article as well. So yes, I would say it's been properly checked by 2 reviewers. And the third part is 3 reviewers independently evaluated the quality of the eligible studies. So I would say there's been a good kind of evaluation. Any questions or clarification, Sarah? Right.
No, all good.
Okay, moving on to the next one, critical appraisal section. It mentions articles individually screened by EV and GA, as I pointed out earlier. The other thing is individual study quality evaluation was done by a Quadas 2 tool. I will explain that in a little bit later. Consensus through the discussion in case of disagreement that has happened in kind of finding out whether it's a quality analysis or not. So another question was, were there methods to minimize errors in data extraction? I would say yes, because there are some methods they have applied to minimize the errors. I'll just explain that first and hear from Sarah if need be. Right, so 2 authors extracted separately. They pooled the data. That is the most important part of meta-analysis. Any of the, let's say, for example, if 10 studies were involved, the pool data is all of them combined and giving on that like data analysis right after. So outcome is based on combination of all of them. They have used a fixed effect model. There are 2 types of model. There is another one is random effect model, but they have used a fixed effect model in this one to compute the pool sensitivity and specificity. They have mentioned about the homogeneity of the studies by doing visual inspection. That is more of a qualitative review. They have looked into the age and trauma mechanisms as a homogeneity as well. I-square, that is one of the way to figure out how much homogeneity or how much heterogeneity that test has got. They used in between the study, and the Q test was used to determine whether the heterogeneity was statistically significant. Unlike any other p-values, because the sample number is very less, we still can say the statistically significant p-value even if it's p is equal to 0.1 or 0.6. I mean, that range. I think I'm not 100% sure, Sarah, if you can add that about the significance once I've finished this one. There were a little bit of publication bias, but it was addressed by Eggers regression test. I'll explain you in a while what that does mean. And there is another data analysis that they have done with the comprehensive meta-analysis V.3. That's a software used to do the statistical testing. So just a bit of understanding of what exactly is this study all about. On the far left, you can see all the study that has been done and the country involved. I just highlighted the number of patients. As you can see, the range is quite significant range, 21 in one of the Weinberg one and the 538 in the Massili one. So regardless of that, the countries involved are USA, Italy, USA, South Korea, Italy and USA, Iran. So basically a lot of countries are involved. That means whenever we churn down that pool data, we get like quite a good evidence of this would work in any other countries as well, based on how it has been explained so far. Regarding the training, I'll discuss a little bit about training in a while. The experience, we're talking about the experience of the ultrasonographer, who are mainly the emergency medicine physicians. And the age involved, as you can see, number 2, Riera, the median age is 2 months to 17 years. So it's like even less than 2 years. And if you see, one of them is Rabina, is 21 years. So that's quite a range that they have taken. But as I mentioned, they actually chalked it out up to 18 only, rather than taking the whole of 18 to 21. All of the mechanisms were mainly, most of the mechanisms were mainly fall. There are some of the mechanisms which includes the motor vehicle accidents and others they have populated under. And the incidence of fractures, right after doing the ultrasound, they have found out 10% incidence, 15%, 64%, 12%, 15%, 77, 14%. That means there were quite a lot of kind of skull fractures that were seen by POCUS. To add on to the findings, what would we be looking at? Just a quick video of how does it look like. So this is a parietal bone, and you can see that fracture, kind of displaced fracture over there. That is the depressed fracture. And these are the suture lines. You mentioned that again. So this is the fracture. And then that's the suture line. It leaves a lot of distance between, but as you can see, there are like a bit of corrugated kind of edges. So that's how we determine the sutures or the fractures. Right. So there's a second one over here. This is quite a depressed fracture. As you can see, this bone right here is actually depressed from where it's supposed to be. Just to give an idea what they were probably looking at. Do you want to interrupt me there, Sarah, regarding the?
No, I mean, you've gone into a lot of detail beyond question 7. So that some of the things that you were saying in response to were there methods to minimize errors in data extraction feed into some of the subsequent questions. And hopefully we'll get a chance to unpick some of the things you were saying around the tests that they ran, but keep going. And
Sure. Okay. So this particular slide shows categories that they have actually specified. As you can see on the bottom, I would just like to mention something about the pooled data A, pooled data B, pooled data C, pooled data D, just to have that in mind. Basically, they mentioned that high percentage of fractures would be seen in pooled data A, and B is for low percentage in fractures. as they have specified two of the articles that two of the studies they have found out with the high percentage, and 1, 2, 3, 4, 5 of the studies they have found low percentage. And in pool data C, they've excluded that patient more than 18 years. In 3 of the studies, they only found those eligible for less than 18, and all studies excluded the all studied and excluded the study that contained patient is more than 18 years. They have put under data C, so group C actually. So there were like 1, 2, 3, 4, and 5 of them were there in that group. So basically, if we look into it, mainly the highest percent of fracture is seen in A, which is in the table itself. If you can see on the left side, top one, it says high percentage of fractures. Those are 2 peri. The green ones highlighted, they have got low risk of bias as well. And another thing, at high risk of bias has also been highlighted over there. Low percentage of fractures, as you can see, the highlighted 1, 2, 3, 4, and 5 of them are in that group. Any questions regarding that?
No, I think there's quite a lot of useful data in that.
Yeah. So I would like to just mention a little bit details, because we've just seen the video, so it can actually correlate well. So if you look at the false positive and false negative area, it mentions that non-calcified suture ipsilateral to trauma were the false positive ones. They actually looked at the suture and said that it's a fracture, that means. And another one is on the number 8 in false negative. So there were 8 for fracture, not underneath the area that was imaged. So basically what we need to know is that wherever we are scanning, we should not actually look underneath the area where the hematoma is. You should be looking all over, compare with the other side as well, check whether the suture is involved or not. And that's when you decide whether this is a fracture. That's why they must have gone into quite a lot of false negative over there. They found out a fracture which was not there. However, there was the fracture, but they missed that. So if you go to the false positive Rabiner one, CT was no fracture, possibly false negative, as the sonographers seem to be convinced that it was truly a fracture. Sometimes with the less of training or the experience as well, you could actually see like a little bit of either a suture, or may not be 100% kind of fracture, but still diagnosed as a fracture. That is probably the reason why it was a false negative one. And if you see the adjacent one, the false negative fracture adjacent to the hematoma and in the area that was not imaged. So if it was not imaged, it is possibly likely to be missed out. And there was one missed out there. Right. In Choi, difficult evaluation area of the orbital wall and fracture skull base. Fracture not in the imaged area adjacent to the hematoma, similar thing. So I just wanted to get an idea about where it could be missed and what could have been done and where they actually overdiagnosed it. So I've finished number 7. Sarah, do you want to add anything on number 7?
Goodness, no. My answer to number 7, were there methods to minimize errors in data extraction? I'd written, yep, 2 authors extracted the data, and that's all we know. very, very
Sorry,
broad.
I had to lay a little bit of foundation for us to understand, but maybe I'm not boring everyone. Right.
No,
okay.
I'm
so,
sure not.
So
No,
the number 8, were the
carry on.
methods used to combine studies appropriate? I would say yes. So they had like a subheading, extra questions underneath this heading. So I just break it down accordingly. Was it appropriate to combine the studies? Say all the studies are prospective observational studies, and all the patients from ED presenting with head injury are the subjects. Number of patients studied from like 21, as I told you earlier, in one of the study, and 538 in another study. So that range of patients were there. Age included were under 2 to 25, but those the patients with GCS of 13 to 15 are only included. If it's less than 13, they would definitely need a CT scan. That's why the focus would not be an ideal thing to do in this case. Have the reviewers assessed heterogeneity statistically and provided some explanation for heterogeneity that may be present? I would say yes, they have written about the I-square value to assess the heterogeneity. Unlike any other study or previous meta-analysis that I've done, it was not clearly mentioned about the p-value. However, we can see that the I-square was 32.14, and I could tell you the I-square value, if we want to interpret that, if you look at the percentage heading right at the bottom, if you see 0 to 40%, it might not be important. That means may not have any heterogeneity, meaning they were probably homogeneous. That is what the conclusion we should make out of it. But 30 to 60%, if it hits the 30% mark, they may have a moderate heterogeneity, but in this case, more of an acceptable heterogeneity we have had. Any explanation, Sarah, there?
No, that was a really neat explanation. I think I would agree with you. What they also did to assess whether it was appropriate to combine the studies was basically just sort of eyeball them. They mentioned it as visual inspection.
Visual inspection, yeah.
Yeah, and that's just, it's like, it's kind of, they just looked really and jumped out at them. And what jumped out at them was that there were two studies with a really high percentage of skull fractures. They grouped those separately, as you've already identified. So they chopped and sliced study data so that they could see if some of the differences, the heterogeneity, affected overall scores. So you didn't need to run they didn't need to run special statistical tests on that. They just looked and saw something appropriate, which is, that's pretty neat, really. So you said you were looking for the p-value. I think you were looking for, in previous systematic reviews, they have used the I-squared test, which you've got the data for there, but they may also have used the
chi-squared test.
I-squared test.
Yeah.
That is where you look at the p-value. So
right.
I-squared just stands alone. It's presented exactly as you've described, and it's a very rough way of dividing it up. But yeah, an I-squared result of 32 is fractionally more heterogeneous than not, but it's not especially a reason to worry particularly. And there are differences in the results in different studies. They've already identified the age ranges are quite broad, the number of skull fractures is different, potentially the experience of the clinicians carrying out the scanning. There's lots of ways that the results could be different in those studies which they've seen to a degree that makes it inappropriate to have combined them.
Right. So you would say no in this, or when you say inappropriate, is it like—
That's the question. Were the methods used to combine appropriate? Yes, I would say that. Yes, they're appropriate.
Okay, I'll move on then. Right. So qualitative review are the methods that has been used to synthesize finding congruent with the stated methodology. I would say yes. This is a pretty standard method they've used to conduct the review. It's called PRISMA. If you can look into this highlighted part, preferred reporting items for systematic review and meta-analysis guidelines. So PRISMA. So protocol was developed. They have looked into the validity and relevance in the identified articles. So there are a few more things I would like to explain right after. So if you look into this—
Can I just stop you there?
Sure.
I know I'm really irritating with the interruptions, but this isn't actually a qualitative review. It's diagnostic test accuracy, but you're right to have identified that they follow the PRISMA reporting guidelines.
Okay, sure. Thank you. So this is what's called QDAS. So Quality Assessment of Diagnostic Accuracy Studies tool. They have used this tool, and as you can see, it's the reason behind when I said yes is when it says quality assessment, I put as a qualitative. So I think that was where I got wrong. Thanks for correcting though. Right. So they looked into 4 key domains: patient selection, index test, reference standard, flow, and timing. So that's quite of explanation that I would need to give, but maybe I'll just wait for the table to come out and then I can explain over there. So I just want to briefly touch base on what exactly is this Prisma, and everybody is talking about Prisma. What exactly is this? And this is actually a supplemental article to the main article. So if you look into the, click on the supplemental part of it, this will pop up. And this usually would be kept empty. But as you can see on the far right-hand side, it's all populated. So based on whatever is in the right and the middle, they've actually explained where exactly do you find what you're looking for. So that's a pretty neat idea about this. So I thought of just bringing out because everybody are like in a first few stages of learning. So I think this might actually help. So just want to move next. So 7 studies were involved, included. 2 studies had a low risk of bias. 5 had a risk of bias in the domain patient selection. 1 study was at risk of bias in the domain flow and timing because the time interval between the POCUS and CT was not actually clear. That's what it means by the flow and timing domain, as I was talking about earlier. So all of the studies were prospective observational study design. And in all the eligible studies, decision to perform a CT was made in advance. So regardless of whatever the POCUS finding would be, they would still get a CT scan. Do you want to add on anything over there, Sarah? Okay.
No.
So moving on, is there adequate descriptive and explanatory information, the final synthesized finding that has been constructed, findings sourced from the original research? As you mentioned, there was a more of a visual inspection that has happened for the review. In one group, so as I mentioned earlier in the figure, in the table, in one group, there were like 2 studies that has a high percentage of fractures that were pooled as a pool A, and others were like pool B that with the 5 low percentage fracture. Pool C was the one which is actually being excluded, and pool D was excluded as well. So accordingly, this was written out. So afterwards, the outcome results per group were calculated. So overall pool data, I square was 32, Q was 8.84. I've already told that. So Eager's regression intercept did not demonstrate publication bias. I'm just going to talk about the publication bias in a bit because I've had like a flyers for that as well. It's basically the same thing again. I don't think there's anything additional to this, so I'm just going to skip this. And about the age as well, I've already explained regarding why they used a different age group based on the study as well. So I'm going to go further. These were the results that were found out. 7 studies were included. All eligible included study included patients for whom the decision to perform a CT scan was made in advance. Overall, the included studies demonstrate a low risk of bias and minor concerns regarding risk of bias. The pool data, the overall N equal to 925, we found out from all of the studies, demonstrate a sensitivity of 91% and a specificity of 96%, meaning when you say sensitivity of 91%, whenever we did the POCUS, we found that there is a fracture, versus whenever we did a POCUS, we specifically did a POCUS, but we could not find a fracture, and that was also the result from the CT scan finding. So it was more specific, meaning more of a kind of prediction for yeah, okay, I'm gonna touch base onto the predictive value as well. Positive predictive value of 88% for whom they have actually done it, and the negative prediction value is 97, which is like what ruled it out. So rule in is positive predictive value, and a rule out is a negative predictive value. I just wanted to touch base upon this forest plot that I mentioned in the previous presentation as well, just to have an idea about, because I'm going to populate the forest plot just after this slide. So in the middle, as you can see, there's a line of no effect. On the side, it says favors experimental. On other side, left-hand side favors experimental. Right-hand side favors control. And the box actually mentions, measures the kind of mean of them study. And all these that you can see are the study. Sorry, this study 1 is not supposed to be there. I think I got it wrong there. But it's from study 2 onwards, all these lines denotes the study. If the line touches the line of no effect, then that particular study may not be significant. But when we say the pool data, we have to think about the final data that as an outcome, which is what you can see in the diamond, which is the precision of the study. It is still on the right-hand side, so we can still accept that as a significant. So in terms of midpoint of it, you can see where you sometimes risk ratio or odds ratio has a midpoint of a 1, but in our case, sensitivity and specificity or anything that is expressed in percentage has a midpoint of 0.5, just to have that idea.
Nearly. You're absolutely right. When the data is being presented in terms of ratios, line of no effect is set at 1, and that makes sense because if scores of 1 mean it didn't mean anything. But where the data is presented in absolute values, or in the case of sensitivity and specificity in percentages, they're absolute values, and the line of no effect is set at 0.
Okay, right. Sorry about that.
That's okay. The forest plot they've presented, figure 2, is an odd one. I've never seen one looking like it, but it isn't quite the same as normal.
That's probably my presumption then. That's why I got caught. Thanks for pointing out, Sarah. So this is the forest plots I was talking about. It doesn't actually look like what I've mentioned, but if you look closely into the first part of it, if you look at the bottom 0.00, 0.5, and 1, so 1 is 100%, 0.5 is about 50%, and in this one, whatever Sarah has mentioned is not actually been populated. So here, it looks like the line of no effect would be 50% as it is written there.
No, still the line of no effect is set at 0. It's not movable. It's either 0 or 1. The 0.5 is there just to give you an indication of.
Right. Okay. So just to see like how far beyond they are.
Yeah.
Right. Okay. Got your point. So as you can see, there's different sensitivity in all of the studies that they have mentioned, but overall data is what we need to look at. Overall is 91% sensitive, which is 0.91, which is just nearby at 1 over there. Even though there were like 1, 2, 3, and 4, which is 4 of the studies, Choi, Rabiner, Riera, and Weinberg actually touched the line of, I beg your pardon, it has not actually touched the line, as Sarah just mentioned. It is just a way they have mentioned about, like, it is just above the 50%. The line of no effect here is 0.00. So none of them has actually touched the line of no effect. They are more close towards 100%. So a pool data is coming out to be 91. Similarly, on the specificity side, which is the right-hand side, and also I would like to mention about the confidence interval on the sensitivity side, 0.87 to 0.94, quite a narrow confidence interval, which is quite good for the study to be actually significant. So in the specificity side, if you see, almost all of them are grouping nearby the 1 label, where there is a more towards 100% specificity, and the final specificity we found out was 96%. Like I mentioned, the pool A, the pool B, pool C, and pool D is mainly to particularly address the certain studies they have actually grouped under. There are several groups that have put under. It's 93%, highest percentage in fractures. They have found out the sensitivity is 93, and specificity there is 89%, but we'll need to look into the pooled overall data, which is 0.91 and 0.96. Any clarification needed there, Sarah? Okay, thank you.
It is a more unusual diagram than your normal standard plot. They're trying to present an awful lot of data either side of the same line of no effect, and I can see how that has been confusing, but hopefully we've made it a little bit clearer for you. It kind of makes sense though, doesn't it? When you've got specificity and sensitivity approaching 100%, that's pretty good. So it makes sense that they're not statistically dodgy.
So moving on to this publication bias, which I mentioned earlier, there was likelihood of a publication bias and which was assessed. This was assessed by Eagers linear regression test. So what does actually a publication bias means? It means it found a positive results and they're likely to be published because they are positive, and they might actually do it more quickly than one with the negative findings. So likely to be published more quickly. So this is what causes the publication bias. Eagers linear regression test is a test which uses to reduce the publication bias, to measure the publication bias based on the inverse variance. It includes study all positive results in favor of POCUS. So the result was P equals 3.13, and they mean to say that they did not demonstrate a publication bias. So it may actually like tickle a head, like, what does that mean? Like, what exactly is that intercept and all they are talking about? Briefly, I'll talk based upon all I know is there a symmetry? Is there a no symmetry? Next one will explain everything. So if you see all those dotted lines, dotted ones, they are studies. So the one p-value less than 1 is like the faintest color they have given. The color in the middle is 1 to 5%, and the darker one is 5 to 10%, and the whitest one is more than 10%. So in this thing, basically, so if you see on the left side, they are more asymmetric. They are mainly on one side. If they are scattered around, which is what is shown in the right, they are more likely to have less bias. So funnel plot asymmetry may not be caused by publication bias. So that's what explained in what I've searched for this in University of Leicester kind of presentation. Does that summate everything, Sarah? You have anything to add there?
Not a bad visual representation, actually. Yes, sometimes you show the diagrams are looking at published versus unpublished studies, and you'd still, once you added in unpublished studies, you'd still expect them to plot in the same way. Taken out of the equation, then sometimes it's hard to recognize the actual funnel shape of the distribution because the unpublished studies are not there. But yeah, thank you for illustrating that. We might need a little bit more work on that on another day, I think.
Okay. So were recommendation for policy and practice supported by the reported data? I would say yes. Moving on to, it's a little bit tedious to look into this. So I'll explain by the diagram itself. As it's mentioned, performed by emergency physicians or fellows, all the studies, ultrasound were done like that. So looking onto that training, they've actually received 1 hour training in one of them. NR is like not really reported whether they've actually trained or not, but they actually did it. Another 1 hour in Paris, another 1 hour in Rabina, Choi, also 1 hour, 2 videos and skills. So they've actually not done any practical sessions. Sorry, they've actually included the videos as well as the practical sessions. Same thing with the theory and skills workshop in Marseille. So they were like, to look at the experience level, they were not fully experienced in almost all of them. They have had a variable experience. So in one of them, 2 of them they have not reported yet, and one of them is clearly reported 1 month to 10 years experience. So they must have been like experienced for several years to detect that POCUS call. So likely chance of incidence has gone high on there based on whatever the number of patients they have had. It's quite a big number. 16 hours, they've found out 64% is incidence, which actually coincide with if you be trained for more hours, it's likely that you will not miss it. That's all I can say about this one. So as we mentioned earlier, from the fracture, I mean the POCUS video that we've shared. So there were 20 false negative cases reported. Majority of the false negative were the consequence of fracture being adjacent to a hematoma and not in the area that was imaged. So underneath the hematoma, probably they did not actually look into. That's what caused the false negativity. And so false positive mainly is they found non-calcified ipsilateral suture, which is probably equivalent to a fracture. They've mentioned that as a false positive. And there were another case of novice error where physician interpreted the ultrasound as a positive, but the expert sonographer found as negative. Another one interpreted during the POCUS imaging as positive for fracture, and during re-evaluation by the expert pediatric emergency physician, there was a minimally displaced skull fracture. However, this fracture was not visualized by the CT scan. So both of them they said yes, but the CT scan finally said no. So still there was always a need of the CT scan. This is what they've started with. All of the patients would go for a CT scan, but regardless, we'll do a prior POCUS scan to see whether you can actually find it or miss it. So recommendation as such, say they have quite good recommendation in terms of POCUS in patients that meet no other major or multiple minor criteria for a CT scan. And consequently, when no fracture is identified, CT scan might not be needed. So especially when someone is suspecting a skull fracture, this becomes more important. The use of POCUS potentially reduce the utilization of CT, unnecessary exposure of children to ionizing radiation. And the bottom line is, it is not to detect the traumatic brain injury. That's what Jbi is all about. But it can actually identify skull fracture, which is an important predictor of traumatic brain injury. So once we see that fracture, we're likely to find another injuries underneath as well. So they have mentioned that future research is necessary to define the role of POCUS in risk stratification for TBI and applicability in clinical practice. So additional research is required whether extending the image area with POCUS will, from the area of the hematoma also will probably increase the sensitivity of capturing fractures that could have been missed out. So the last bit, sorry guys, a bit lengthy one, were the specific directives for new research appropriate? I would say fairly appropriate, because there can be debate about it from Sarah, but I would say fairly appropriate. They mentioned that POCUS proved to be the option for ruling out skull fractures in children visiting after blunt head injury. There are some limitations, but we can still look into whether we can actually implicate this in the clinical practice. So as Mr. Junjua is very keen on finding out whether this was funded or not, they have not actually declared about a specific grant for funding agency in the public or non-profit sectors. So this is just a summary. Before that, do you want to hit on anything particular points, Sarah?
No, I'm not going to delay your summary any longer.
Right. Okay. So aim of the study was to evaluate the sensitivity and specificity, positive predictive value, negative predictive value of POCUS in identifying the fractures in children. POCUS was used because it decreases the radiation, it is non-invasive, and it decreases the time in A&E and no need for sedation as well. And it's and the sedation side effects could actually be dealt with without having to go for a CT scan, which needs a sedation. The study actually highlighted that it has had high sensitivity and specificity to identify skull fractures in children with blunt head injuries. One thing I forgot to mention is more training is necessary for the clinicians in order to find out possible fractures. And also POCUS can serve as an adjunct to increase the accuracy of clinical decision rules regarding using CTs after head trauma. And there are several further other research is actually required. However, it can actually serve as an adjunct. That's what I take home with this. So final thing is overall appraisal. I would include this in my clinical practice probably. And clinical bottom line is focus can effectively rule out skull fractures in children visiting the ED after blunt head injury. These were my references. And thank you guys. Any questions? If you are, please raise it.
Thank you, Suraj. Thank you, Tilak. Now I will defer to Boone to tell me, but I think we're probably out of time for questions.
What's the time now?
Well, I think if anybody wants to comment, you should. There's still plenty around. There's still 80 people around.
Yeah, you're right. Yeah.
That's fine. I'm afraid I'm going to have to dip out now. I will.
Okay.
What a fascinating morning.
Okay, thanks you guys.
Thank you for the being moderator, Sarah.
Please don't forget the feedback. Okay. And the feedback deadline is Sunday.
Bye.
Bye. Thank you.
If you haven't got any questions, thank you guys. Thanks for listening.
Bye-bye, everybody.
Bye.
See you next week.
Bye-bye. Have a nice evening.